a little message in the chat and just letting me know. Okay. Lovely, right, so we'll get started then. So I'd just like to thank Dr. Medhat Basta for helping me verify all of these slides. He's a really knowledgeable consultant and he's been very, very helpful in my medical school career and my career as a doctor so far. So just before we start, we're going to have a brief discussion on safeguarding at the end of the session, which will include mentions of sex work, sexual assault, rape, grooming and child protection. So if you feel that any of that might be potentially upsetting for you, please don't make yourself sit through it. If you'd like to just send me a private message in the chat, I will try my best to give you some extra support if you need, or just step out of the session by all means. After the session, I'll upload some links to some support if anybody needs that. And I originally had all of the sources and patient information leaflets in the presenter notes, but I've realised when you upload it to Medal afterwards, it doesn't include the notes. So I will put a link to a Google Doc after the session that's got links to everything, all of my sources, all of the images I've used, and some extra resources as well. Okay, so our learning outcomes for this session. We want to be able to recognise common presentations of HIV within and outside of sexual health contexts, to be able to describe treatments for HIV, including necessary monitoring, follow-up and need for compliance with treatments, to be able to confidently take a sexual health history, including risk assessing and safeguarding as appropriate, and to recognise the stigma and difficulties faced by people living with HIV. So, first of all, what is HIV? So, these two definitions are a little bit wordy, but essentially HIV is a virus that infects and then multiplies inside our cells, and it basically destroys our immune system over time. With a destructive effect on the immune system, essentially what happens is we become immunodeficient, and when you don't have a working immune system, you're more likely to get what we call opportunistic infections and other infections, as well as the development of types of malignancies, so cancers. And then as HIV progresses, it turns into what we call AIDS, so acquired immune deficiency syndrome. And it's the late stage of HIV infection that occurs when your body's immune system is damaged because of the virus, so your immune system isn't working properly. It's scientifically defined as a CD4 count below 200 cells, or development of those opportunistic infections, and we'll talk about what those are later in the session. So how do we transmit HIV from person to person? So it's transmitted through unprotected penetrative sex, so that can be oral, vaginal or anal sex. Sharing of needles, so in your intravenous drug users particularly, that's quite a big risk factor. Infected blood products, skin grafts, organ donation or artificial insemination. Rarer, but definitely still something that happens, and at least in the UK, I can't speak for other countries, but when you give blood, it's always tested for HIV, amongst other things, and that's the reason why. And it can also be passed from mother to baby during birth or breastfeeding, so we call that vertical transmission. So risk factors for HIV: MSM, so men who have sex with men; transgender women; IV drug users, like we mentioned before; needle stick injury, so working in a healthcare setting, that's something that can happen. I know lots of people who've had needle sticks at work. It's not a big deal if it happens, but it's something that you do need to go and get blood tests for. And one of the reasons why is because it's a risk factor for HIV amongst other infections. So we have high risk areas around the world, and in the session resources after, I will put a link to this map, which I thought was really interesting and helpful, and it gives you, I like things when they're set out visually, and seeing the colours just makes it really clear and you're able to kind of see where HIV is more common. Sex workers and a high maternal viral load for that vertical transmission between mother and baby. So how does HIV present? So stage 1 is the acute HIV infection. So this is also known as a seroconversion illness. So if you ever hear that, that's essentially the same. And this sort of diagram on the right-hand side, I think, gives a really nice visual representation of all of these stages if you're a visual learner like I am. So you can get flu-like symptoms, fever, headache, rash, chills, night sweats, muscle aches, sore throat, fatigue, swollen lymph nodes, and mouth ulcers. One of the things to note about seroconversion illness is we want to keep it in the back of our heads, especially if you work in an area where HIV is quite prevalent, because I'm sure you can all appreciate those symptoms are quite generic, and you could put all of those down to just, one of those viruses that goes around, everyone picks it up and everyone gets a bit unwell and then you get over it. But it's really good to keep in the back of your mind, could this be a first presentation of HIV? During this stage, there's rapid multiplication of HIV and it's highly infectious. So again, with people not necessarily recognising that the symptoms they're having might be to do with HIV, they might not change anything about, sleeping with sexual partners, and without knowing, they're transmitting the virus to potentially lots of people. After this stage, you go to stage 2, which is chronic HIV infection. So this is asymptomatic and it's known as clinical latency, so the virus is latent. There are absolutely no symptoms in this stage. People can go living as they were before, and HIV multiplies quite slowly in this stage. So as you can see on the diagram, it's more over years that this stage might occur. And then as we move on, we get to the point of AIDS if the person hasn't accessed treatment until this stage. So this is also known as late stage HIV. So it's severely damaged the immune system. As we mentioned before, it's defined as a CD4 count under 200, or the acquiring opportunistic infections. So because our immune system is so damaged, we can't fight off infections that otherwise wouldn't be a problem for us. Again, you have a high viral load, as you can see with the amount of sort of brownish coloured dots on the far right of the diagram, and so you're highly infectious. Again, you can get some sort of generic symptoms in this stage, so rapid weight loss, fever, night sweats, extreme fatigue, swollen lymph nodes again, diarrhea, mouth and genital sores, pneumonia, and we'll talk later when we talk about opportunistic infections about the certain types of pneumonia that people with HIV can get in this stage. Memory loss, depression, neurological disorders, and skin discoloration. Okay, so our opportunistic infections. So these are things that if you diagnose a patient with any of these infections, they need an HIV test. What's really important is if you are going to do an HIV test for anyone, they need to know about it, they need to know why you're doing it, and they need to give consent for that. And informed consent is the key part here. So the difference between regular consent and informed is the key word, is that people need to know the benefits, the drawbacks, the reasoning behind it, and be able to weigh those pros and cons up by themselves and make a decision that's the best for them. So certain types of thrush, a lot of the time in late stage HIV, you can get oral thrush that's so bad that it goes down to the esophagus. Obviously, thrush is something that we diagnose a lot, so I'm not saying every single person that has minor oral thrush needs an urgent HIV test, but if you're seeing repetitive thrush or extensive thrush, that's when I would definitely consider testing. Tuberculosis, M. avium complex, so this causes respiratory problems. CMV, cytomegalovirus. And then PCP, so this is one of the weird and wonderful kinds of pneumonia that people with damaged immune systems can be more susceptible to. It's a fungal pneumonia, so if someone gets this, their immune system is very likely to be damaged quite severely. Toxoplasmosis, so this can infect the brain. When I link the extra information, I'll try and remember to put a scan of someone's brain with toxoplasmosis. It's really interesting. You can sort of see lesions in the brain. Cryptococcus neoformans, again a fungal infection, and coccidioidomycosis, which is another fungal infection. So you can kind of see a trend. A lot of these infections are fungal in nature, and when your immune system is damaged and not able to perform like it would normally do, we're more susceptible to these kinds of infections. Okay, so if you suspect that any patient you see might have some symptoms that could be because of HIV, we've got some different tests that we can do. So we can do an ELISA, which is enzyme-linked immunosorbent assay. So essentially it's a blood test, it's serum. So the window period is quite short, which is great because a lot of the time with the older tests for HIV, you had to wait quite a few weeks before it would be a reliable test to do, which, especially if you're working with patients that maybe aren't very compliant with healthcare or have a bad relationship with healthcare, asking them to come back in, 10, 12 weeks time, you might lose a lot of patients to follow up. So being able to do it really close to the potential exposure is very, very good. Obviously, that is when using the most advanced tests, so it depends where you're working, where you're studying, and what's available in each service. If you get a positive ELISA, you need to confirm it with a Western blot, which is quite an expensive test, or you can just do a repeat ELISA. Another option is just a serum HIV rapid test, so that's a point of care test. If that comes back positive, you need to confirm with a blood sample that you send off to the lab. You can also do a buccal saliva test. I've actually not seen this done in the community in the sexual health centres that I have studied in and worked in before. Usually they'll do finger prick blood tests, but you can use this as a surveillance testing method, so just testing the general population to pick up incidental findings. And you can also do an HIV DNA PCR, so a similar method to a COVID test, and it can diagnose HIV during the window period. It's expensive and usually used in infants. So if we do have a positive result, there are some tests that we need to do for every patient. So our CD4 count and our RNA or our viral load, we need to do those. So viral load is a way of measuring how infectious someone is, and we'll talk about being undetectable and untransmissible later in the session, so that will make more sense. And then our CD4 count is basically a representation of how effective our immune system is. So like we mentioned before, if that's under 200, that is the definition of AIDS, late-stage HIV. Anyone with a positive HIV test needs a full STI screen, including hepatitis A, B, and C, which again is a blood-borne infection. Hopefully, if you're considering an HIV test, the person may already have had a full STI screen done, which is great, but if not, that needs to be done. And then blood tests for non-STI testing, so a full blood count, using these liver function tests, lipids, random glucose, an HbA1c for a baseline, so the glucose and the HbA1c are to look for diabetes, varicella zoster, so chickenpox or shingles to a layperson, measles, rubella, HIV viral resistance tests, because what you don't want is to put someone on medication that isn't going to work against the kind of HIV that they have. And then not everyone does this nowadays, but you can do an HLA-B5701, which is a lot of numbers and letters, but essentially if a person's positive for that, there's one particular kind of antiretroviral that you can't use because they'll be allergic to it. So all of these need to be done before starting treatment. The generic blood tests at the beginning, so when you're starting antiretroviral therapy, it can be quite tiring on your kidneys. We like to get a baseline for each patient, and also people with HIV are more susceptible to other conditions that we see in the general population, so things like heart disease, high blood pressure, high cholesterol, diabetes. But in people with HIV, it's really important to keep a close eye on it because, again, with antiretroviral medication, we just want to make sure that we're keeping them as healthy as possible. So, treating HIV. So all patients need to receive antiretroviral therapy as soon as possible after they're diagnosed. And when we counsel our patients, at least in the services I've worked in before, they will usually have a long appointment with a health advisor, so someone that's trained in looking after people who are newly diagnosed and also people with existing known HIV, making sure that they get all of the care and the information that they need. As part of that counselling, we need to make sure we tell people that antiretroviral therapy doesn't cure HIV, but it can reduce their viral load, so their HIV RNA, to undetectable. And as you can see on the right here, there's been a big media drive in the last few years to get the word out to the public, U equals U. And essentially what that means is if your viral load is undetectable for 6 months or more, it means you can't transmit HIV to any sexual partners. And you can also apply this to other situations. So, for example, say you were a healthcare professional that was HIV positive. If you were undetectable, there's no restriction, as far as I'm aware, on performing things like cannulas, anything with a potential needle stick injury, because you can't transmit HIV to any of your patients or your colleagues. So it's a really empowering thing for patients. And also, I think, puts into perspective for people why it's so important for them to be compliant with their medication. Because if you're taking it every single day as you're meant to, and you're undetectable, it can have a really positive effect, not just for you with your personal health, but with others if you're not able to transmit the virus. So I think that's quite an empowering thing to tell our patients. So in terms of what we give patients, it's usually 2 NRTIs, so nucleoside reverse transcriptase inhibitors, and 1 other agent. So it can either be an INSTI, an NNRTI, or a protease inhibitor. Now, all of these are very long names, and when I was in, I think it was second year of medical school when we were still preclinical, we did do the whole how does HIV infect a cell. The reason I'm not covering that in this session is I really doubt that that will come up on the MLA. I think the MLA is more clinical, and I think essentially what you need to be aware of, at least from my experience, is the clinical side of things and knowing how to spot signs of HIV and look after our patients. I doubt they're going to ask you to explain the cellular aspect of it. Can you please click? Sorry, I'm just reading the chat. Is that better? Hopefully that's got rid of that. Okay, so usually patients will have 2 NRTIs and 1 other agent. Nowadays, we've had some advancements in the way that we can put together different formulations of drugs. So now you can just have 1 tablet that has all 3 agents in, which is great for patients rather than having to take 3 separate tablets every single day. And we've also invented injectable HIV medications. So these aren't used extensively, at least not up in the north, as far as I'm aware. But they are a great option for patients who might have barriers to taking medication every day, might want to keep their HIV status private from other people who might, see them taking medication every day. Lots of really good options. You only have to go to the clinic every 8 weeks to have it, which is great. If you are on oral medication, it's important that patients know they have to take it every day for the rest of their life. I think sometimes if people aren't explicitly told that, they might think, well, if I feel better after a certain amount of time and my CD4 count has gone up, my immune system is better, I don't need to take my medication anymore. But it's really important that we educate our patients that if they stop after that point, they'll go back down to where they were before. And one of the great things about antiretroviral therapy nowadays is that people with HIV can live a very normal life as anyone without HIV would. Life expectancy is basically normal for people with HIV as long as they're compliant with their medication, which is just amazing because, as we'll talk about towards the end of the session, that wasn't always the case for people, unfortunately. Okay, so I quite liked this infographic. I thought it was quite a nice patient-friendly way of explaining what antiretroviral therapy does. And also, I quite like reading patient information resources when I'm trying to learn about something new because they put things very, very simply and makes it very easy to understand. And then you can use that patient-friendly language when you're talking to patients, and I find it makes everybody much clearer on what's going on. And as it says here, like I said before, it prolongs life expectancy to near normal, which is amazing. Okay, so for patients who are at higher risk of getting HIV, we also now have medication that they can take, which is called pre-exposure prophylaxis or PrEP. So HIV PrEP can be taken by people at higher risk of HIV. Sex workers, IV drug users, people with a partner who is HIV positive and still has a detectable viral load so they can still transmit, and this reduces their risk of getting HIV. So I found some really interesting statistics. People who take PrEP consistently are 99% less likely to get HIV from sex and 74% less likely to get HIV from injecting drugs. So our most common forms of PrEP are usually two antiretroviral medications. So Truvada is, I think, a pretty well-known brand name for HIV medication. Or you can have other forms such as Descovy. So Truvada can be taken by anyone at higher risk of HIV, whether it's from sex or IV drug use. And Descovy is for sexually active men, so people assigned male at birth, and trans women who are at higher risk of HIV. It's not for people assigned female at birth who are at risk through vaginal sex. And it's also recommended in renal impairment, which is great. Again, you can get injectable PrEP now, which is good for people who, like I said, might not want to take medication every single day. They only have to do it every 8 weeks, which is great, but they do have to be able to come and attend clinic for that. So again, that might be a barrier for some patients. Oral PrEP can be taken every day, which is known as continuous PrEP, or you can do it event-based. It depends on the needs of individual patients. So your event-based PrEP, you take one tablet before your potential exposure event, and then you take tablets for 48 hours afterwards. So it's really kind of a shared decision between healthcare providers and patients, depending on what their preferences and needs are. Okay. So we also have post-exposure prophylaxis. So this is known as PEP, and it can prevent patients getting HIV after a potential exposure. So this needs to be started as soon as possible after their exposure, so ideally within 24 hours, but up to 72 hours after exposure. It won't be effective more than 72 hours after. And it's usually a 28-day course of oral medication. If someone is having PEP, we need to do a few investigations, so User-Knees and liver function tests. We'll do an HIV test, hepatitis test, a full STI screen, and a pregnancy test if that's applicable to the patient that you're seeing. And then they need an HIV test done at least 45 days after they've completed their course of PrEP. It's usually done 12 weeks after starting PEP because that aligns with the syphilis testing window. And they may also need emergency contraception. One really recent development in PEP, which I think is amazing, is you can now, in the near future, we're going to be giving what's called doxy-PEP. So it's the usual course of PEP and then a short course of doxycycline. So this can prevent patients potentially from getting things like syphilis as well, which I think will be a really great advancement in sexual health medicine, and hopefully will prevent lots of patients from getting syphilis. I don't know if any of you have been keeping up to date with trends in STIs the last few years, but syphilis is really on the rise, particularly among MSM populations. So I think, especially with MSM populations knowing so much about PrEP and PEP, having the option to give them doxy-PEP will hopefully provide lots of benefits for them and for everyone, and for the NHS, because I'm sure it's, I don't know the figures, but I'm sure it's probably cheaper to give doxy-PEP than it would be to treat syphilis, but don't quote me on that. Okay, so I've popped in a couple of things from some guidance. When I give the post-session notes, all of the links to the full guidelines will be in there. But this is basically telling you when PEP is suitable to be offered to patients. I won't read through the whole thing, but essentially it's a really clear guideline, and some of the stuff might surprise you. So, for example, down towards the bottom, sharps and splash injuries, sharing of injecting equipment, receptive or insertive vaginal intercourse when the index case is from a high-risk group but the HIV status is unknown. PEP is generally not recommended, which surprised me. But I think nowadays, because we know a lot more about the transmission of HIV and we're able to risk assess better. It saves people having to take a long course of medication, which is also good. And again, I won't go through this table, it's just something to be aware of after the session, but this is a really clear table that tells you when we should and shouldn't be giving PEP for patients. Okay, so the next part of the session, I just wanted to talk about HIV in the media. I'm not sure if any of you are interested in sexual health or GUM or in infectious diseases as a career, or you've been interested in the history of HIV, especially its reflection in the media, but the perception of HIV has definitely changed a lot since it first came about. So if we look at the top left picture, I don't know if any of you have seen this advert. I will link it in the post-session resources, and I will also link one that was from Australia. So when HIV was first sort of discovered, there was a lot of fear-mongering, and there were two really famous adverts. So the one that I've linked was made by Britain, and it essentially showed a tombstone, and it was quite a reductive advert, and it was essentially trying to scare people into not having sex with anyone, and it was telling them that they would die of AIDS. And this was obviously a big problem at the time, because this was before the invention of antiretroviral therapy. So I don't want to deny that people were unfortunately passing away very young from AIDS, but I was surprised at the tone of the advert. So I would give that a watch. One of the big turning points in the public perception of HIV and AIDS was when Princess Diana visited people with HIV and AIDS, and she, as you can see in the bottom left photo, she shook the hand of a person living with HIV. Now, this might not seem like a big deal for us, but back then there were a lot of misconceptions about HIV. People thought you could catch it through spit, which is not true. They thought you could catch it by sharing towels or touching someone with HIV, and it really contributed to this spiral of hatred and fear-mongering about HIV, and it caused a lot of homophobic hatred at the time. So I think Princess Diana doing this and being in such a public position really changed people's perception of people living with HIV for the better. If you're interested in learning more about people's experiences of HIV through sort of an easily accessible media source, I would really recommend It's a Sin. It's a short TV series, very, very, very good, and it's about a group of friends living in London during the emergence and sort of this stage in history where everyone was misinformed potentially, or fear-mongering about how HIV and AIDS came about and were spread. It's really beautifully written, it's heart-wrenching, but it's a really, really good watch, so I'd recommend it if you're looking for something new to watch. And then, as we've gone through time, thankfully, perceptions of HIV have become much better, and we're doing a lot of work within healthcare to educate the public on how HIV is transmitted and how we've come along so far in treatment of HIV. So there are lots of really amazing media campaigns. I mentioned U equals U before, which is great. We've also got this new campaign where we're trying to become the first country to end new HIV cases by 2030. I mean, that would be amazing. I hope we're able to achieve that. And there are loads of charities. One of my favourites is the Elton John AIDS Foundation. Obviously, Elton John is a big celebrity. Lots of people are aware of him, and I think it's amazing that he's trying to raise awareness and raise money and support those living with HIV and their families. Okay, so just before we finish, I wanted to do a little bit on safeguarding and advocating for our patients in sexual health. So obviously, regardless of what kind of medicine you enjoy or end up practicing in your career, safeguarding will feature regardless of who you're looking after. but I find it comes up a lot more in sexual health because of the nature of sexual health. So some of the examples I thought of are we often have more time and we can take a more detailed history. I often joke that being, working in sexual health, you do kind of have to be a bit nosy about patients in a professional way, of course. But as part of our work, we find out a lot about people's personal lives, and that can really help us keep people safe and ensure that everything that they're experiencing is safe and consensual. So the nature of sexual health, we want to give our patients lots of privacy. We see patients generally by themselves, no relatives or friends in the room. So that might create a more comfortable environment for people to disclose anything they might want to talk about. We see a lot of young and vulnerable people in sexual health as well, and we see sex workers a lot. We have lots of opportunities to identify possible trafficking or grooming. We do a lot of intimate examinations in sexual health, so we might be able to see injuries that might make us think that we need to risk assess for assault or rape or FGM, so female genital mutilation. That's another thing that I think is really important to keep in the back of your mind. There's a lot of built-in safeguarding in sexual health, so I'm not sure whether any of you have heard of the STICARD scheme, but it's a UK-wide programme where young people can get access to free condoms, not just at sexual health centres, but at pharmacies or corner shops if they've signed up to the scheme. In order to access the scheme, the young person has to come in and get some education on safe sex, STI transmission. We have a good old chat to them, and during that we do a safeguarding assessment, and that can be really, really helpful to identify possible issues or things that the young person might need more support with. And then there are also links between sex and drug and alcohol use, so someone might be doing sex work to fund drug use, or if they're in times of financial hardship. And then chemsex is also a big thing, so people using illicit substances during sexual encounters. And we can ask about these in a sexual health setting, hopefully in a non-judgmental way, and build a good relationship with our patients, and hopefully they would feel comfortable talking about any problems that they're having. Okay, so I thought I would just do a couple of SBAs at the end, because I know that's quite a big part of medical school, and hopefully they'll help you sort of consolidate what we've talked about today. So if you wouldn't mind, I'll read out the question if people could just pop a guess in the chat. So our first case is a 35-year-old female who presents to occupational health following a needle stick injury whilst at work. Her patient is known to be HIV positive, but their viral load is unknown. Which of the following would be the most appropriate plan? So A, wait until the patient's viral load results are back before starting PEP. B, start PEP immediately and give a 14-day course. C, start PEP immediately and give a 28-day course. Or D, PEP would not be indicated whether the patient's viral load was detectable or not. So I'll just give you a couple of seconds to have a guess. Don't worry if you're not sure of the answer off the top of your head. I can pop back to one of the tables. That might help you. I wouldn't expect you to memorise this for the MLA. I'm sure they would give you something similar to this in order to help you answer that kind of question. Okay, so yep, we've had someone say C, which is correct. So as per our table, if someone's HIV viral load is unknown and you've had a needle stick injury, PEP is recommended. And as we talked about before, it is usually a 28-day course. So yep, C is the correct answer there. Okay, so SBA 2. A newly diagnosed HIV positive patient books in at their local sexual health clinic for some advice about taking antiretroviral therapy. They have no other past medical history, no allergies, and have 2 regular sexual partners. Which of the following statements is true? So A, antiretroviral therapy cures HIV. B. Antiretroviral therapy prevents AIDS no matter how long after diagnosis patients start taking it. C. HIV can be transmitted through all bodily fluids, including saliva. And D. Antiretroviral therapy can prevent transmission of HIV if taken properly. So again, I'll give you sort of 20-30 seconds to have a go with that one. Okay, so the correct answer for this one is D. So like we said before, if you take your antiretroviral therapy as prescribed, so that's usually once a day, if you're on the oral medications, you can become undetectable, and if you're undetectable for a certain period of time, you become untransmissible, so you can't pass on HIV to sexual partners or through any other bodily fluids. Okay, and our last question before we finish for the evening. A 25-year-old trans man who was assigned female at birth presents to his local sexual health clinic to discuss starting PrEP, so that's our pre-exposure prophylaxis. He explains he would like PrEP as he has one-time casual sexual encounters, vaginal and anal sex, with male and female partners on nights out. This usually happens about once per month, and he would prefer not to use condoms with his partners. He did a full STI screen, including blood tests, last week, and all the tests have come back negative. He has no other past medical history, no allergies, and would prefer not to have to attend clinic regularly if possible. You counsel him thoroughly on the benefits and drawbacks of PrEP, including that it does not prevent other STIs, and he's happy to continue with PrEP. Which of the following would be the most suitable option for him? And I just realised as I read that out, I just wanted to clarify, he's the receptive partner in those sexual encounters, because that will change our perception of what we can use in terms of PrEP. So I'll give you a few seconds to have a little look at that. Okay, so this question potentially has two correct answers. The one that I think is probably the most suitable for this patient is Truvada event-based PrEP. The reason why is twofold. So we don't want continuous use, preferably for this patient, because he's only having once a month encounters. So rather than him having to take medication every single day of the month, if we do event-based, he'd only have to take it surrounding those sexual encounters. The other reason I picked oral event-based PrEP is he wouldn't have to attend clinic as often as having injectable PrEP, and that sounds counterintuitive. We can give several months of PrEP at a time once someone's established, and we know that they're going to come back for their blood tests when they need to. So potentially the injectable PrEP would also be an option for this patient. I think those two, so B and C, would probably be the two most suitable options for this patient. We would just need to see what their preference was. I probably would have gone with the oral event-based PrEP. The other thing is PrEP can be quite hard on kidneys and liver, so rather than having a constant supply of PrEP going around the bloodstream from the injection, being able to do it event-based reduces someone's exposure to that, and hopefully not, this person doesn't have any existing medical conditions, but it's always better to give the lowest dose possible. So that's why I went with Truvada, but I could definitely argue for giving the injectable as well. Okay, so that's the end of our session for this evening. Thank you all so much for listening. I hope that it's been informative and that you've learned something. So I will have some articles coming out. I'm sorry if any of you were at the last session. Mind the Bleep has recently changed the way that we're going to be publishing articles, so we are launching a new website called mlamedics.com. So my last article didn't come out on Mind the Bleep. This new website's being developed, and that's where they'll come out. So hopefully in the next few weeks to months, and you'll be able to access a couple of different articles. So I've got one on gram staining and microscopy in sexual health. If you attended my last session, it's a really easy way of point of care diagnosis for different STIs. And then I've got one coming out on sexual health in the media as well. So we'll be discussing lots of different TV shows, films, books, and museum exhibitions that you can use to broaden your knowledge of sexual health without sort of just knowing about the academic side of it. And then there'll also be one coming out on how to confidently take a sexual health history, some tips and tricks that I found useful for example, for calming nervous patients or providing reassurance to patients, being able to explain things, and making sure that you respect things like additional needs and disabilities that patients might have as well. So those will be coming out soon. I would just like to answer a question in the chat. So Paul has asked, event-based relies on having access to meds at the time, or can it be used for some hours post-sexual activity? Okay, yeah, so you want to take one dose of PrEP before the sexual encounter. So this can be a barrier to some patients if you're doing event-based PrEP. So you need to know that you're going to have a sexual encounter. I mean, there's no harm if you take it just in case you don't have a sexual encounter. You don't have to finish the course. That's also an option for people. But yeah, it relies on you sort of having a plan. So if patients, I've seen some patients who are very spur of the moment, which is, completely fine, who wouldn't necessarily be able to guess when they're going to have a potential exposure to HIV, in which case continuous might be more suitable for them, or an injectable method potentially. But if you're able to predict, so the way that patient in the example said, usually it's a once a month thing, it's a casual encounter, but then being able to kind of predict when it's going to happen, as long as they've taken one before, and then you take one tablet a day for 48 hours afterwards. So you don't necessarily need to have the medication really quickly after the potential exposure. It's just one the next day. Like, for example, if you were having sex on Monday night, you'd take one pill on Monday afternoon, one on Tuesday, and one on Wednesday, and that would be you done. So definitely, if patients aren't able to predict and take that one pill beforehand, that could be a barrier to them, but you don't need to take it immediately afterwards by any means. If anyone's got any other questions, feel free to pop them in the chat. And yeah,